Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. My guest today, I think, is going to be a really riveting one. It's Dr. Atul Batra, who's an additional professor of medical oncology at the All India Institute of Medical Sciences, or AIIMS, in New Delhi. And he's also the senior author of the PLANET study. It's a very compelling study that evaluated low-dose pembrolizumab in addition to neoadjuvant chemotherapy for triple-negative breast cancer. And it's really a big part of a growing body of research that shows balanced efficacy when we use lower doses of immunotherapy instead of standard doses to reduce cost as well as potentially toxicity. I think this has huge implications for our global audience, and I'm so thrilled to have you on the podcast today. Dr. Batra, Atul, welcome.
Thank you, Dr. Paul.
And we'll just take it with first names from here since we're both friends. I have to give the audience some context. Atul, I had the great honor of visiting AIIMS New Delhi. For those that don't know, this is really, the Harvard Medical School of India. It's the most competitive institution for medical training. And on the back end of that, there's also incredible resources when it comes to clinical trials and infrastructure. I just wanted to have you give the audience sort of a scope of the types of trials that you've been able to do at AIIMS New Delhi.
Thank you, Monty. So I work at the All India Institute of Medical Sciences, and we had the honor and pleasure of having Monty here this month. And people are still in awe of his lectures that he delivered there. Coming back to our institute, so it's kind of a medical college. It's one of the oldest one. It was built in 1956. We are lucky enough that we get the best of the residents and fellows because they have to go through an exam, a competitive exam, and mostly it's them who come to us, and we are able to do some good work out here. Regarding the trials that we have conducted, we do conduct some investigator-initiated studies, and we try to answer the questions where we can help our own patients. Like, for example, this PLANET study, every other patient in the clinic was almost not able to afford Keytruda at the full dose pembrolizumab, and we had a lot of evidence creeping in that a lower dose might be helpful. And that's how we planned this study. Before that, there are certain cancers that are peculiar to India, like gallbladder cancer, head and neck cancers. These are much more common in India as compared to the US. And there are some good studies that have been conducted from our own institute by our senior colleagues, which have been presented at ASCO and published in the JCO. We also did the capecitabine hand-foot syndrome study that was known as the DTORCH study, 1% diclofenac, a gel that became the standard of care to prevent hand-foot syndrome. So that's kind of a brief overview of investigator-initiated studies. India is slowly and steadily becoming a partner of the global registration trials. And it's more recently, last 5 years or so, we have seen that the number of phase 2 and phase 3 trials are increasing, and we are able to offer now these trials as well to our patients.
That was a terrific overview. I just want to highlight for the audience, as we go through some of your discussions today around specific trials, the speed at which this can be done. Just for context, for me to accrue a clinical trial of 30 patients, I think many people have probably come across some of the work that I've done in the microbiome space at a single institution, 30 patients, right? It takes me about a year and a half, 2 years. We're going to go through some trials today where Dr. Batra and his team has actually, in fact, accrued close to 200 patients over a span of just a year, which is just remarkable by, I would say, any American standards. So I see a real need for partnership and a tool. I'll kind of get back to that at the end. But without further ado, the focus of this podcast today, I think, is really this terrific presentation you gave in an oral session at ESMO and then subsequently published in Annals of Oncology related to the PLANET study. Would you give the listeners some context around what the study entailed and population and so forth?
So we know the Keynote 522 became the standard of care for triple-negative breast cancer, where Keytruda, when added at 200 milligram, the standard dose every 3 weeks with neoadjuvant, increases the PAT-CR from around 51 to 64% by a magnitude of around 13%. However, in India and other low-middle-income countries, less than 5% of the patients actually have access to this dose of pembrolizumab. So our standard of care was actually just chemotherapy till now. And this kind of led us to design this trial. There are data that comes from previous trials conducted in India, from the Tata Memorial done in head and neck space, some other studies done in Hodgkin's lymphoma that a much lower dose, probably around one-tenth of the dose, works well in these cancer. So that's where we designed the Planet study, where we gave the standard neoadjuvant chemotherapy in the control arm. And in the experimental arm, we added 50 milligram of pembrolizumab. This was given every 6 weekly for 3 doses. So that's a total of 150 milligram over the neoadjuvant period as compared to 1600 milligram that was given in the Keynote 522 study. So this was almost one-tenth of the study.
So a tenth of the dose, which is just remarkable. I mean, that's just such an interesting concept.
And the results, the primary outcome, this was a phase 2 study. We just wanted to see, is there a signal of activity? And to even our surprise, when we looked at the pathological complete response rates in the control arm, this was 40.5%. And in the experimental arm, this was 53.8%. So a difference came to around 13.3%, which was numerically, so much similar to what Keynote 522 had with just these many doses. So this was around 160 patients randomized over 1 year. We could randomize them in 1 year because of the load that you see. And the primary endpoint was met, and we could see that the complete response did show a remarkable increase. We are still following these patients to see whether there is a difference in event-free survival at a longer follow-up. Till now, it's a small follow-up. So the number of events absolute are different. 4 events in the experimental arm and 11 events in the control arm. So we are seeing some signal even in this much short follow-up period as well. But we need to see more what happens in the longer term.
That's so impressive. I wonder, with this lower dose, do you attenuate toxicity at all, as far as you can gather?
So although we should be doing kind of cross-trial comparisons, but if you look at thyroid dysfunction, we saw that around 10% of our patients had these thyroid dysfunction. This was compared to 15% in the Keynote 522. That was a larger sample size though, but we are seeing that all the toxins are somewhat less as compared to those in the standard dose. So the exposure is less, but I can't really commit definitely on this. For this, we would need much more data to say this with more confidence to say.
Yeah, I'm going to ask you a really tough question to follow up. And this is probably something that's on everyone's mind after reading a study like this. Is this something that is disease specific that needs to be replicated across other histologies? The reason I ask this is, you think about paradigms like, for instance, in the States, we're toying between intravenous versus subcutaneous delivery of checkpoint inhibitors. And we have studies focused on specific histologies that might justify use across all histologies. With this particular phenomenon, do you think we need to do dedicated studies in renal cell or in colon cancer and other places where, in selected settings, we might use checkpoint inhibitors and then decide whether or not there's this dose equivalence, if you will?
That's a real tough one, though. But I'm happy to share that there are several ongoing studies within India. Currently, at our institute, my colleagues are leading studies in lung cancer space, cervical cancer. There was already a publication from Tata Memorial in head and neck cancers, and we see that the signal has been consistent throughout. Regarding renal cancer, there was one study that was presented for sure at one of the, I think, ASCO from CMC Vellore. That's again a center in South India. That was an RCC, that a much lower dose. And for patients who cannot take the full dose, we actually are offering lower dose nivolumab in such patients. And we are seeing responses. We haven't done those randomized trial again because the numbers are much lower in kidney cancers, we know. We could do this trial in triple negative one because we had support and we had numbers to conduct this trial. But I'm sure this should be a class effect. When we can get tumor agnostic approvals, then some real world data has come up in almost all tumors. We have seen that consistent effect across tumors. And as we speak of today, I'm also delighted to share that in India, yesterday, we had the first biosimilar of nivolumab, and that's now available at a much, much lower price than the original patent product. There was a long ongoing lawsuit that was there. That's over now. And from yesterday onwards, I'm so happy to share here that we would have the first biosimilar of nivolumab that's available. That's going to bring the cost to almost like 1/10 already.
Wow, that's huge. I'm going to be very selfish here for a second and focus on a study that is in the renal cell space that your group has done. When I came out I was really sort of intrigued by this study as well. And it reflects sort of a different capability, I think, of AIIMS New Delhi. And that's in the what I'm going to call biomarker space. This, for the audience, was a prospective effort to characterize germline variants in patients with advanced kidney cancer. And it's something that we talk about a lot in the kidney cancer literature, whether or not we're missing a lot of these so-called hereditary patterns of RCC. Can you tell us a little bit about that study too?
Yeah, so that was led by one of our fellows, Chitrakshi Nagpal, and she's just completed her fellowship. And 2 years back, we published that. So that was done in almost 160 consecutive patients that we recruited over the span of just 1 year. And we saw, apart from the common known mutations in RCC, that was around 5% or so. But a lot of other mutations were also seen that we don't generally see in kidney cancers, and we see in other cancers like BRCA1, BRCA2, and others. We are still, doing those analysis to see whether we get more things out of there in the somatic. Is there a loss of heterozygosity, or was it just present and in there?
I thought it was a terrific study. And again, I was just so blown away at the pace. I mean, as I look at 140 patients recruited over a span of 1 year, this is something that would take us perhaps 3 times as long at City of Hope. And that's with a very sort of what I consider to be large and dedicated kidney cancer program. So it really underscores, I think, the need for collaboration. And ever since I came back from my visit to you at AIIMS Delhi, I think I've just been sort of transformed in the sense that trying to think of better ways for us to collaborate. One tangible thing that I'm going to get cracking on is seeing whether or not perhaps we can form some partnerships through SWOG, or what we call the NCTN, the National Clinical Trials Network here within the US. Talk to me about collaboration. I mean, you've been really terrific at this. How do you sort of envision collaboration enhancing the global landscape of oncology?
That's really amazing, Monty. That's what we need. We have the infrastructure, we have the manpower, we have patients. These are all high volume centers. Unfortunately, we are a little less in numbers, so we are more clinically occupied as well. So sometimes it's kind of tougher. But again, when it comes to helping out the patients, global collaboration, we need to kind of take you guys along with us and have our patients finish trials earlier. This is win-win situation for patients, one, because they also get exposure or an option to participate in the clinical trials. And second, we can answer all these scientific questions that we have at a much faster pace. All those things can be done within a much shorter span of time for sure. We are so happy to hear that. And with open hands, we are ready to collaborate for all these efforts.
That's awesome. I came back thinking, gosh, this would be so ideal for some of these rare subtypes of kidney cancer, prospective clinical trials that I'm running in that space, where really we're threatened with closure all the time. And if we just sort of extended a hand to, our partners in India and other countries, I'm sure we could get this research done in a meaningful way. And that's got to be a win for patients. Atul, I had such a terrific time chatting with you today. I'm looking forward to seeing lots more productivity from your group there. By the way, for our listenership here, take a look and see what AIIMS New Delhi is doing under the leadership of Dr. Batra and others. It is just a real powerhouse. And I think that after doing so, you'll be enticed to collaborate as well. I'm hoping this is the first of many times that we have you on the podcast. Thank you so much for joining.
Thank you so much for having me here, Monty. It was a pleasure, as always, speaking to you. And thank you again.
You got it. Well, and thanks to our listeners. I encourage you to check out Dr. Batra's paper. We'll actually have a link to the study in the transcript of this episode. Finally, if you value the insights that you heard today on the ASCO Daily News Podcast, please rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.